Hello, and welcome to the view from Highland Park. Before we start the show, I want to dedicate this show as a memorial to our former technical director, Mark Toulouse, who we lost much too early in his life. And we all say a very special prayer for him and his family. I also want to thank our director, Ron Levitsky, and our crew, Larry, Irv, and Julian, for being part of our show today. And to our special guests, Don McAvoy. He's a former British citizen who is also part of senior producers, and he agreed to come on our show. And on my left here is Pam Chill from Chill Out. Wonderful show.
Thank you.
And the other wonderful show is Joyce Bernstein from 30 Minutes with Joyce. Welcome all of us to the show. And what we're going to be talking about today is Medicare for All. Is it a good system or not? And so we're going to start with our special guest today because he is originally from Great Britain, and he was in a system where there was Medicare for All. So we're going to talk about the pros and the cons today. And I'm going to start with you, Don.
Okay.
Welcome to our show.
Thank you.
Glad you're here.
Thank you, everybody. Well, basically, I must point out to all who are interested, I haven't lived in Britain for almost 60 years now. I immigrated to this country. I became an American about 5 years later. And I've been back to Britain many times. I have been to Britain and stayed maybe about 4 months. I have received medical care over there, and I've received, of course, umpteen medical care over here. I don't think it's fair necessarily to compare the British and the American systems, okay? I think if you're looking at the British system, you have to compare what the British had before they had a National Health Service. I don't want to go into all that because that will take a whole nother session. But what they have now is sufficient that I do not know of one person that I ever met there that would exchange it for the American type private insurance system. And private insurance is available, but it's a very minor part of the population that chooses to use it. Okay? Getting to where we are today, though, we're talking about Medicare for all. And I've come up through the ranks. I was in a medical practice for a time, not as a physician, but as a medical scientist. And I worked in hospitals, and I worked in private laboratories. And I got to know something about the way fees are set, the way people are charged, the way insurance companies work in terms of paying laboratories at least, and also about Medicare. And I must tell you about Medicare in terms of the lab experience. In laboratories, in 1984, I think, prior to 1984, laboratories were doing work for doctors' offices. And the doctor would take the specimen, he'd send it off to whatever lab he could find that gave him the cheapest price. And then he would bill the patient. And we were one of the labs that doctors would use. And Medicare, and of course, in the process, the doctor would mark up whatever we charged him. And just as an example, I'll take Pap smear. Pap smears were very common. Of course, a large volume. We would charge our doctors around about $6 for a Pap smear. And out of curiosity, one day, we had a couple of the cytotechs who read these things in the laboratory call various obstetricians' offices and to obstetrician gynecologists' offices and said, what would you charge me for a Pap smear? And basically the price ran anywhere from $25 to about $70. And that was the markup on a $6 test. Well, in about 1984, and they would pass that charge on to Medicare. The patient would pass it on to Medicare. About 1984, I think, Medicare came up with a rule. No more markup on lab tests from doctors. We are going to have the laboratories bill us directly, and we will pay the laboratories directly. Many doctors actually had about 30 to 40% of the income was generated from marking up lab tests. Okay, so Medicare said, we're not going to do this anymore. We're going to pay the laboratories directly, and the laboratories will send us a bill. And they came up with a fixed fee that the laboratory industry had negotiated with Medicare. And the fee, I forget the exact amount now, I think it was ended up somewhere around about $10, okay?
But I wanted to check with you, now you're for Medicare for all.
Yes, certainly I am. Because I think for one thing, they are the one thing that's made Medicare work is they control prices. Patients do not pay a nickel for a lab test these days.
Okay, but if we did Medicare for all, and I want to address this to Pam, U.S. physicians purchase their own education, not like some of the other countries that that their education is subsidized by the government, and so when the doctors here, the physicians here, bear the significant burden of complying with the state and federal mandates. And I know that your husband is a physician, and how do you and your husband, since he's a physician, feel about Medicare for all, and how would that put him, what kind of position that would put him in? I mean, right now, we have Medicare for all. Some of us, at lunchtime, we were complaining that, right now, some of us get 10 to 15 minutes on our appointment only. Medicare for all, I was thinking maybe we'll get a 2-minute appointment. Let me hear what you feel about it and what your husband, and you have discussed about Medicare for all.
We have discussed it at length, and for the physician, there are two types of physicians. There's the one that's in private practice, which is self-employed and carries the burden of all the overhead, which is the rent, the payroll, any supplies that are needed, any testing that is needed. And then there is a physician that works for strictly the hospital, and then they carry the burden. Okay, for the doctors who do work for the hospital, obviously it isn't as much of a concern because they are not, directly will be affected by this.
They're salaried.
They're all salaried, yes. And they will not suffer from the burnout. They will not suffer from having not to have their fees cut once again, and to get approval for every single referral that is done. Because right now, anything that is an Advantage plan that is like Medicare Advantage, you have to get a referral. So the primary care doctor really becomes a gatekeeper of, you have to refer to other doctors, and any procedure, unless it's an emergency procedure, has to be pending a referral. So it is a great deal of work. In our practice, we have one person who does virtually nothing but referrals and studies, the compliance through each Advantage program.
Do you feel that patients are going to, Joyce, do you feel that patients are going to get good care? Right now, a lot of us do and a lot of us don't. But if everybody gets Medicare for all, do you think the quality of our services is going to be better, or is it worsening?
It's hard to tell. We don't really know, but at least the person will have care, and if they're in have private insurance, they can't afford it sometimes, and they just neglect it. So this way, it's more of a help to people, Medicare for all, I think.
So it keep people healthier.
Yeah,
because people
of
will
course,
go
young
to
people don't really care that much. I don't think it won't make that much difference with them, I don't think. But for other people, it gets so expensive that it's just out of hand, and I think this is a help to them.
But let me ask you, Don, do you feel, a lot of people I know in Canada, and I was wondering, I'm sure this is part also of England, that if say you need a hip replacement or you need a knee replacement, and they say to you, I'm sorry, but that's elective surgery. You can't, like here in the United States, if we feel that we need a knee replacement, a hip replacement, we need an MRI or a CAT scan, we can go and get it within a week or two. But I hear cases, I know, in Canada, and I'm wondering if it's the same in Great Britain, that if they feel it's not urgent, you could wait anywhere from a year to 2 years to get that hip replacement or to get that knee, the knee replacement. What is the situation if you in England? Is that the same?
I honestly don't know. I mean, I did not come here as an expert on the English system. I honestly don't know what it would take. I never needed a knee replacement when I was in England. And I don't know anybody that did. I would imagine that there would be some delay, yes. But certainly I did need a cardiologist when I was there, not because of an emergency, but just a routine matter. And I saw the cardiologist within 10 days. Here I can wait 2 months for a cardiologist appointment. But I just don't know. And I hear these stories about Canada. Of course, I've never been a patient in Canada, so I don't know what goes on there. And I didn't, explore the Canadian system. What I'm concerned about is the system in America. We have, in Medicare, in my judgment, we have one of the best insurance plans, certainly in the United States, and possibly in the Western world. And we're foolish to try to destroy it. The alternative to Medicare that exists for most people is private health insurance. And when you look at the costs of that, these are truly phenomenal. There was a study done not too long ago by the, the OCM. I'm sorry, I misplaced the. Here we go. The OECD, which is an international body that still includes the United States, believe it or not, of which there are 38 democracies get together and they decide on economic systems and so forth. And they, not too long ago, about 2017, they looked at what was the cost of healthcare as a percentage of the gross domestic product. Okay? America came out 16% of our gross domestic product was spent on healthcare. The next nearest one was Switzerland, where the percentage was 10%. What do we get for that extra expense? Well, we do all kinds of good things. First of all, the health insurance companies do very well. Their CEOs make, there's not one that makes less than $10 million a year. And recently in the United Healthcare Group, David Wickman, his total compensation reached $21.5 million.
And you're talking about in the industry of health, people like Blue Cross, Blue Shield, United Healthcare.
Somebody has to pay for that, and that somebody is you and I.
Yeah, by premiums. But here's another thing, and maybe you could, Pam, you could address this. Medicare rates do not reimburse enough of the overhead for a U.S. physician to sustain his or her practice. Medicare, the ready implication mechanism for Medicare for all, reimburses even less. Do you feel that your husband or the physicians that are coming abroad, young physicians, are going to stay in practice for long? And how are they going to sustain if they're, because I remember when I was in practice, I'm a psychologist, years ago, I would get reimbursed immediately, say from one of the companies, one of the health insurance companies like Blue Cross Blue Shield. Say I charged $100, I would get $100. Then as the time went by, I would not get the $100 anymore. I would get $40, and they wouldn't pay 2 weeks later. They would pay 6 months later. Now, luckily, I have other income that I sustain myself, but what if I was a single mom and I had to live on $40 that I get 6 months of each patient, $40 6 months later, half of my fee that I charge, even less than half the fee? What do you do then?
Well, Medicare, as we say it, does pay in a timely fashion. It's Medicaid that takes a very, very, very long time, and some of the other policies. But
I didn't. That wasn't. I didn't have Medicare. I was just giving
private insurance.
Private insurance that was
right.
doing it that time.
Yes.
It was wonderful. It used
Well,
to pay great, and then it would cut everything down in half.
They've really lately, paid again in a timely fashion. I think it'll put an end to some of the deprived areas where you have a rural area and you need a physician and you don't have a hospital setting. I think that there's no way that they'd be able to sustain themselves. And as far as the bills that have been written, there are very tight restrictions of even doing anything other than having a contractual agreement with the government, as far as, having some type of private pay, like if somebody's here from a foreign country. If somebody is not a citizen, they're not set up for it. If they want to have a procedure that is not covered, anything elective, psychological counseling, whatever it may be, acupuncture, chiropractic treatment, we don't know how that's going to come into play. As far as the bills that are written now, it doesn't say anything towards that. So there are different, avenues to do. In my opinion, Medicare for all, there is also the thought, too, of doing the highest percentage insurance rate, which is from 50 to 64. Because younger people obviously don't have as many problems, and they have the highest rates. And, the higher you get up to in age, till you reach the Medicare age, then you have the higher premiums. It's like from 58 to, especially 58 to right about that 64, that they're very, very high. And there are other ways of doing it. Instead of doing Medicare for all, as you were saying, when you have CEOs of insurance companies making multi-million dollars, and somebody, wants a procedure done from, let's say, hypothetically, United Healthcare, and that procedure is denied, they can't have that procedure because they haven't had the CT scan to have the MRI, and it wouldn't necessitate it, or they had one done 5 years ago, and they're not going to pay for another one. That's how they make their bonuses. And it's not all salary, it is bonuses on top of that.
Yes.
So, there are different avenues that I just wanted to address.
We're talking about
Sure.
really huge amounts of money here.
Oh, yes.
Do you know, this new guy has just been appointed head of Department of Health and Human Services, works for the government. Alex
Absolutely.
Azar, his name is. His salary, working for the government, is $209,700. Now, I think that's kind of low. He started with like 340, and he voluntarily decided to cut it because of politicians' objections. But compare that with the man I just mentioned in charge of United Healthcare.
Absolutely.
Makes $19 million.
Yeah, I agree with you. And I'm also just wanted to just
Why do we need that kind of stuff?
To tighten the antitrust laws for hospital companies so none can become regionally dominant, which you have hospitals buying up other hospitals. So it's monopoly. They're doing the
It's
whole
starting
pricing.
now.
Yes.
Hospitals are eating up other hospitals.
Absolutely.
That small hospital no longer exists.
It does not exist.
Yeah.
Right.
Yeah, because a lot of the 3 and
Yes.
4 hospitals are going together under one umbrella right now.
Tax hospital profits and non-doctor hospital salaries at confiscatory rates, outlaw the charge master, the hospital outrageous list prices that they determine, and control prescription drug pricing and in the hospitals. Just an example, if you have a patient who is on a certain type of diabetes drug, you will not be able to get in the hospital because it's too expensive. You'll get another drug. You'll have a substitution, so that poor patient, does not have the drug while they're in the hospital, and they are not being observed properly. They can get hypoglycemic shock. There are different things that can happen.
And now if you go to a hospital, you don't even get your own doctor. He doesn't even come to your husband still comes to the hospital, but more and more doctors are given up.
The hospitals want the hospitalists. Yes.
They want hospitalists.
They want hospitalists.
And they do not know that patient well. And so a lot of times you're in the hospitalist doesn't realize you have a secondary infection coming up. They don't see it because your doctor needs to see. Sometimes I know I have a son who's a general surgeon, and he's right now he's very fortunate that he gets to see each of his people, and he says without him doing it, a lot of times a patient could develop an infection, and the hospitalist doesn't see it right away, and because he's there, and visits his patient every day, he sees it to prevent an infection from occurring. Another thing I want to address, Joyce, you're sitting over there, and I think this is important, is that there are now fewer college graduates applying to medical school because many of those students are worried on how to pay for such an expensive education and the debt that they will incur afterwards if it goes to Medicare for All, which does not pay doctors well, and they will have to see abundance of patients, and they don't see how it will work, because a lot of these, like countries like England and Canada and all these other countries pay for their doctors' education. The United States doesn't. It has to come out of their pocket. How are they going to get reimbursed? And they're going to have to see so many patients that it's going to be exhausting. And you see fewer people going into medical school. What do you think about that?
Yeah, I know. Well, this has nothing to do with medical school, but my own doctor won't even belong. She said, they're not going to pay my salary and tell me what to do. I'm going to be my own doctor and make my own money. And different countries have different priorities, right? How much they pay. Every country with Medicare isn't the same. Is it like different? Like England isn't the same as Canada, is it?
Or probably different than Sweden. Each one has their
Each
own.
one has their own.
Some have a
Regulatory
like I
committees.
know Israel. They have both. They have both private. They have both public health insurance and private. I think England has also private and public, but Canada, as far as I know, they don't have private insurance. I think it's only public insurance.
I believe so, but I cannot.
But can you imagine what do you think about the doctors are not applying to medical school because it's so expensive, and they have a feeling that they're not going to be reimbursed, and they're going to have to see an enormous amount of patients.
As I said again, and I just want to reiterate, there very few will be going into the private practice. They'll be
when we're
working
talking
for,
about
hospitals
Yes.
and clinics, that clinic will be a derivative of the hospital, a subsidiary of that. And they will have quotas, just like, people who were sales. They'll say you have to, see a patient every 10 minutes, you have to order so many tests. I mean, to make an additional income to raise profits.
Mm-hmm. And probably some of those tests are not even going to be, right now we do the MRIs and the doctors cover these tests, their offices. Pretty soon we will not be able to get those tests because they're too expensive. So we'll get something that's less expensive for the government. Remember, government insurance, the government is going to be watching over us.
Yeah,
and I know Medicare is a government thing, but when it comes to Medicare for All, who's going to pay for all this? Yes,
Who's going to pay for it? Who's paying for the same CEO's salary? $21 billion in profit was made by the 5 top insurance companies in the United States last year. $21 billion. Who's paying for that? Okay, think about that for a moment. Regarding the education of the physicians, I agree. The education I got my education, and it was paid for by scholarships from the government. But isn't that a different topic? Shouldn't we have another session on what to do with education? Because education is a mess too. Education.
Yeah, we'll invite you back for education. We need it.
We've only
Joyce-
the iceberg, as they
We
say
made
right
a
now.
joke about it before, that doctors are the cheapest people when they go out there, tips or anything, because they had to pay so much to go to medical school.
Right.
And that should not be a factor. And we're kind
I
of.
know it was just a joke, but it is.
It's true. It is true.
Pay for health care. I'm not interested in how much the doctor paid for his education. My concern is how much, as the American public, paying for their health care. But his education should be a different
Our health care, Medicare people right now, their money to pay for the health care is from their Social Security check. And I think I mentioned.
No, it isn't.
Yes, it is. All the Medicare is paid. My Medicare is paid for. My Medicare comes from my Social Security check. My Social Security check for the month is $200. So a lot of all my everything that I have comes from my Social Security check. Where are these other people? If they're younger people, they're not on Social Security. Who's going to pay for this Medicare for
let me
all?
correct you, first of all.
Yeah.
Everybody, when they start work, they pay what's called payroll taxes. Part of that pays for Social Security, part of it pays for Medicare. In fact, I think it's about 1.45% of everybody's salary is paid by individuals right from the day they start work when they're 18 or whatever, right till the time they retire, okay? 1.45 from them and 1.45 from the physician. That pays for Medicare. And that gives you Medicare Part A, all right? Medicare Part B is paid for from general revenues of the government. In other words, from income tax.
But who's going to pay? Who's going to pay for all this, though?
And for a premium.
Yes.
And for a premium from each individual who's retired. Like you're talking about. But that's a minor contribution, and that doesn't start until you go on Medicare. Insurance should start when you leave school. Insurance should begin then. Social Security begins then. Everybody's happy with the Social Security.
Yeah, so they need to find some way to get this right now.
Fine.
Right now, if it
Let's
stays the way it is, who's going to pay for it? Do you have
The
any
monies that you would be spending
Yeah.
on private insurance.
Well, we will, all as individuals, I know we're running out of time, will have to pay for Medicare for all. And, you know, I'm sure there'll be a lot of restrictions. You're having Uncle Sam in your pocket is basically what it is. And I'm sure it'll be cost prohibitive for a lot of people. And they'll probably book caps on things that you can and cannot do. I don't know.
Medicare
And
for
what
all.
are they going to do with torts, too? The people get sued and
tort
stuff like that.
reform?
Yeah, tort reform.
That's a whole other issue. You know, the legalities involved. I think Illinois is one of the highest malpractice.
Right.
Yes.
What are they going to do about
Where
that?
they have punitive.
Yeah, they're going to have to
Yes.
do something for Medicare for all. How are they
Yes.
going to do all this? This is like, it's really going to be a lot more complicated than we think it is. I don't know how, because I know that Bernie Sanders, it's called the Burdens of Bernie Care. Voters should know Mr. Sanders is promising miracles when what he'll deliver is poor care for everyone.
Who wrote that?
Me, no. The Burdens of Bernie Care. It was
yeah.
it was an opinion of the Wall Street Journal.
I mean, you'll have a lot more, you know, NPs and PAs, and you'll have a lot more probably telecare, you know, where you can, you know, put yourself on the computer and your doctor will analyze you.
Yeah,
right. So there'll be, you know, different avenues that'll be less expensive, more immediate care. You know, you can probably only go to an emergency room if you meet this criteria, you know, that they'll pay for it. Who knows?
So I think people should be happy the way it is. I think people, because I think there's a lot of problems, yes, but then look at the other alternative. You know, sometimes what you see, you know, sometimes it's better in what you get. What do you think? The two of you, they're sitting there. What do you think, Joyce?
Well, first of all, when people have private insurance and they can't afford it also, does that mean they don't get the care? Now with Medicare, do they get the care?
But they can't afford it. There's Medicaid right now.
Well, a lot of people aren't eligible. There's such strict rules to go
And so
with
that's
that.
another problem with Medicaid.
And
You
they
can't get doctors
A
to,
friend of mine
yeah.
was on that. They
Oh my
canceled their
gosh.
doctors.
Very,
Yes.
very limited amount of
Wait a
doctors.
minute. She has to wait 3 months. They change her appointment because the Medicaid doctor's not going to see her right away. She's going to wait.
And sometimes a Medicaid doctor turns out that he no longer wants to do Medicaid, so then you have to find another doctor.
I know
And
she has a
yeah,
terrible
That's
time. She
my-
can't
Yeah.
get care.
yeah.
It's
Yes.
my understanding that if it was Medicare for all, there would
It
not be
means all.
there would not be a means test, and there's a means test for Medicaid. Medicaid would disappear, and it deserves to disappear. Okay, I don't see why there has to be a means test so you can get health care. I think health care should be a right that people are entitled to, and I think that right ought to be covered by the entire community, the entire population.
And I see that one of our camera people is getting to the point where we have to start wrapping the show. But I want to thank all of my guests today, to Joyce for contributing, and Pam from Pam.